I'm the CEO of the Belgian eHealth platform. That's a government institution, not that big, about 50 people. I will explain what we are doing and especially how we organize the exchange of data between all actors in the healthcare sector in a very secure way. I will first give you an overview of the basic vision on information security and data protection, and then how we implement it by a number of structural and institutional measures, a number of organizational measures, and a number of technical measures, and then I will conclude. So here we have the context. We have about 11.8 million citizens in Belgium. We have about 100,000 healthcare providers of all kinds, physicians, dentists, clinical labs, pharmacists, and so on. We have about 300 healthcare institutions, like hospitals, like rest and care homes. The reimbursement of the costs is organized by the sickness funds. There are a lot of sickness funds. They are organized in unions, but nearly in every municipality there is a local sickness fund. And we have a number of public institutions. We're quite a complex country. We have a federal level, we have regions, and all of them have competences in the area of health and healthcare. We have a Minister of Public Health, we have a National Institute for Health and Disability Insurance, that's the one who's controlling the sickness funds. We have an Agency of Medicines and so on. So this is the context. The health platform has been created now about 15 years ago. I come from the social sector. I also, I'm the CEO of the Belgian Crossroads Bank for Social Security that was founded in the 90s of the last century. And that organizes the digital exchange of data between all actors in the social sector, and they asked me to do it again in the health sector. So the eHealth platform is a public institution, has to promote and support well-organized electronic information exchange between all those actors, with necessary guarantees related to information security, data protection, and professional secrecy. And the aim is to optimize the quality and the continuity of healthcare provision, the optimization of patient safety, that there are no errors, to simplify administrative burden, and to use also the data for what we call secondary use. So that means research, scientific research, healthcare policy making and evaluation. And we have, so we are created by law. We have in the law a number of tasks, developing a vision and strategy, being the motor of changes, organizing the cooperation between all those institutions, determining technical and functional standards, specifications, checking whether the software, we don't develop software for electronic patient records ourselves, but we check whether they meet the requirements and specifications, especially the level of interoperability and security. We have a number of basic services that are usable for free by everyone, and a lot of those services concern the aspect of security. We make division of task agreements. We have we have authentic sources, the concept of authentic sources, so the data are not centralized, they are decentralized. They are stored in a decentralized way, but we agree between the actors who is storing what data, who is checking the quality of what data, and so on. And we also act as a trusted third party to pseudonymize or anonymize data in order to be able to use them for scientific research and policy making and policy evaluation. So this is the global architecture. AS is authentic sources, so these are databases where data are available at the level of hospitals, at the level of pharmacists, at the level of medical doctors. You have the value-added services. These are software packages that are used by the hospitals, by the healthcare professionals and so on to do their work. And what we are doing is trying to make it possible that in a secure and interoperable way, they can exchange all data that are necessary to deliver qualitative healthcare, and also that every actor only has access to that data that are relevant for them. I will explain these basic services at the end, the last part of my presentation. But here you have already an overview. You see that we have a kind of middleware that organizes processes between all those systems. We have an integrated user and access management system that checks whether the one who wants to have access to data is entitled to have access. We have a central logging system so that citizens can check who has access to what data, when, and for what reason. We have systems for end-to-end encryption, as well in a situation where when the information is sent, the destiny is known, as in a situation where it is not the case. I will explain it. We have an eHealth box with embedded encryption. So this is for asynchronic data exchange. We have a timestamping service. We have a service for coding and anonymizing data. We have a reference directory. I told you that the data are not available at one central place. So it is important to know what data about what people are available where in the network. And then we have a unique identification number for all Belgian citizens and basic identification data, address, and so on. So this is stored in a national register, Rijksregister in Dutch, and everyone has access to. It's very important that if you exchange data on a certain person, that you are sure that you're talking about the same person. So these are a number of figures. So last year we had about 19 billion exchanges. So that means, in average, 1,400 for every Belgian citizen a year. That's a lot. So you see that the system is working. The system is based on an informed consent. So people, data are only exchanged when there is informed consent from the citizen, from the data subject, that the data can be changed. But of course, nearly all citizens have given this informed consent because it concerns the exchange in situations where it is needed to deliver qualitative care. We check that the system is only used by healthcare professionals and by the patients, so they get certificates from us in order to prove who they are. And you see that the whole system of prescription of drugs, the access to data that are available in clinical labs and hospitals, you see the number of exchanges on that. And we also have a system of a summary electronic health record. So that's the main data about allergy, about vaccination situation, the medication scheme, the problem list that you have. So nearly half of the people have such a kind of patient summary that is available in a health vault. I will not go to the European aspect, but you probably know that there is a European health data space regulation. And by 2029, a number of these services will be available throughout Europe. We have yesterday a meeting with the strategic committee. We are organizing a system where when I have a problem and I'm in Spain, the medical doctor in Spain can access my data in Belgium. Again, after having checked that he's the one who pretends to be, that he's a medical doctor, there's a therapeutic relationship with me, and so on. So the model that we have here will be used on a European level. Of course, we have a lot of discussions in the parliament, with the medical doctors, with lawyers, and so on. How do you organize this in a correct way? In my opinion, it's about having a good balance between fundamental rights. You have the right on privacy protection, the fundamental right on privacy protection. It's in the Belgian constitution. It's in the Charter of Fundamental Rights of the European Union. But you also have the fundamental right on qualitative healthcare. It's two fundamental rights. And in a number of situations, you have to make balances between them. And a good way to do it is to do it on the basis of a risk management, a risk assessment system. So I will explain how we try to have the advantages of the exchange without having problems with security and with privacy protection and so on. It's perhaps useful to know that people can make complaints on the system. It's already since 3-4 years that we have no complaints. So that means that people trust the system and that the way we secure the exchange is correct. So what are the main topics? How do you organize it on a global way? So we have a number, I will explain it, of structural, institutional, organizational, technical measures according to policies. One of the main principles, it's also in the GDPR, is that information can only be used, can only be treated for purposes that are correct, and that we have measures on the several levels that data cannot be abused and that there is no use possible. It's not only technical, but also organizational and legal for purposes that are not compatible with the normal purposes. We have a whole system in order to guarantee that the data are only accessible to authorized actors and users according to these purposes, the business needs, the policy requirements. We have, and that's quite unique. Yeah? They are copying it in other countries now, but we have an Information Security Committee. It's a committee designated by the Parliament. It's very independent. And every type of data exchange has to be authorized by this Information Security Committee. It's a multidisciplinary committee, so it contains medical doctors, it contains lawyers specialized in data protection, and it contains IT people specialized in security. And it's there that it is checked whether the data exchange is compatible with purposes, whether the security measures are correct, how the data minimization principle is respected, and so on. And these authorizations are public. We have it's for the social and the health sector, we have about 40 decisions every month. So there are 10 meetings of this committee a year. So you see that everything is regulated beforehand, and that we have a kind of preventive system of checking what has to be done. As I told you, every electronic exchange of personal information is logged, and people have, in a certain way, access to this logging. So they can see what data have been exchanged between what actors and for what purposes. And of course, people also have the right to access and to correct the data. And we have an obligation since a long time that every healthcare institution of a certain certain level has to be a data protection officer in an advisory, stimulating, and documentary and control task. So the structural and institutional measures, there is no central data storage. We don't have, it's not the case in every EU member state. In a number you have a central storage of data, but we have chosen, this was what was wanted in a societal way. We don't have a central data storage, so the data remain at the level of the several healthcare institutions, healthcare actors, and so on. We have put in place a number of basic information services, security services. I will explain them later on, but you have already had an overview. They are not mandatory. The healthcare actors and the software companies don't have to use it, but they all use it. It's a generally used set of basic services. So we guarantee that it is secure, and they can then concentrate on the development of business applications to help the users use the system. And we have this independent information security committee designated by the parliament. So these are a number of guarantees we put in place on an institutional and structural level to do it. I already explained what the information security committee does, how it is composed, and so there are decisions with binding value. Everyone who exchanges data has to respect what is in this, these decisions, and they can also define good practices. They can support the data protection officers of the institutions, and they have a yearly activity report that is quite interesting to know what is happening. Here you see what are the considerations in these decisions: lawfulness, purpose limitation, data minimization, integrity and confidentiality, and transparency for the data subjects. Skip this one. On the organizational level, so it's not the case for every individual pharmacist or medical doctor, but the healthcare institutions have the obligation to have a DPO, an information security department headed by a DPO. And some types of healthcare institutions are subject to the NIS2 regulation. They have to prove compliance based on either ISO 27 or cybersecurity fundamentals. I don't know whether it was already explained here, but we have a Center for Cybersecurity that has defined a number of cybersecurity fundamentals, and these things have to be respected. It is also the basis for a number of minimal security standards. We have an information security committee that meets nearly every 2 months, and it is composed of the DPO of the eHealth platform and a number of DPOs of hospitals, of other types of institutions. And it's there that they discuss about the implementation of the policy and how to do it. It is very important, in my opinion, that the regulation, that the policies are not defined in a central way without buy-in of those who have to implement it. It's very important that we take into account the concrete situation of the institutions, and that we have buy-in, that they are really used and respected. We have also at least one specialized information security service provider, because we have a number of little institutions that don't have the capacity to cover the whole security problems, and they are supported by this kind of information security service providers. And we use a number of tools, like the data protection impact assessment of every thing we are doing. And when we put in production new systems or new applications, I will explain to you a kind of unique file where, in a multidisciplinary way, it is respected that a number of measures are taken. So the eHealth platform was created in 2009, but the obligation for the hospitals to have this kind of DPO already exists since 1993. We're also connected to the Crossroads Bank in the social sector, not for health data, but for social data. So they already have this obligation since then. And in every hospital, there is such a kind of information security department with the roles that you can see. The cyber fundamentals. So since NIS2, Belgium also has a kind of center of cybersecurity. They are doing good work. We are working together with them because they have some kind of basic principles, good practices, but covering all sectors. And we are trying to translate it with their help and with buy-in of the security officers in the hospitals, in the rest homes, and so on, to make it concrete, applicable in the healthcare institutions. You see what kind of things are defined in this cyber fundamental framework on governing, on identification, protecting, and so on. And of course, there is a liability if these things are not respected. The DPO of the eHealth platform tries to coordinate all these things. So he has an internal control function, an advisory function, but he's also the motor of this information security committee. And he works in close cooperation with the Information Security Committee. So that is organized in that way. We are using the data protection impact assessment system that is foreseen in the GDPR. And we have defined a tool or created a tool that can be used to support that. The tool has as a first function kind of basic screening, whether a more detailed DPA is required. We have a set of risks. As soon as 2 risks are present, we think that a DPIA is required. And the definition of what is a risk is developed on the basis of criteria that are defined in the GDPR by the Belgian Data Protection Authority and also by the European Coordination Working Party on Security. If a DPIA is necessary based on the fact that there are at least 2 risks, there is a first step that makes it possible. We have a kind of database of possible risks, so a checklist. They will evaluate more in detail by using this tool whether the risks are present. And then you have a first, so this is a view of what it contains. It's in Dutch, but okay. Then you have a first risk evaluation without measures taken to to manage the risks. Then you can try to indicate what measures you will take to manage the risks, and then you have an overview at the end of what is so this is immediate without measures, and the end result indicating on what level you should take measures. So this is a tool, it's public, you can download it, and we use this tool for every new type of application, every new type of data exchange. It's from the startup to the delivery of the project, and we reiterate it every 3 years for every application so that we stay well tuned with the new situation. And unique file, so that's important that when we go in production, that on the legal aspect, it is checked that we meet the requirements, that on the technical aspect we meet the requirements, that the authentication levels, the authorization system, the activity loggings and so on, that they are well in place. So it's a kind of general overview. The GDPR also asks or imposes that every system is well documented. So this is the documentation of every type of data exchange we are organizing. And then some more information about the technical measures, and there I will explain them a little bit more in detail, because it's a course on security, so I think this is quite important. So I will not explain all of them, but give you some examples. So the first thing is so our system can be used by actors in Belgium that are active in the healthcare sector, and we need to be sure that it is the case. So that's why we deliver certificates. So every healthcare provider generates its own key pair, and we use this system to be sure that the one who is connecting to the system is the one who pretends to be, and that the healthcare professional, the healthcare institution is active in the health sector in Belgium. It's also the basis to encrypt and decrypt messages. For instance, when they are using the eHealth box. And it's also a fallback system. In Belgium, we have an electronic identity card. There's also a system for mobile authentication. It's me and a wallet. It's 3 systems, in fact. When there is a problem with one of them, this can be reused. The certificate can be reused to have continuity of service. So for every service you can, it's described on our website. You have the link where you can find it, and you can see how it works. The second basic service, and that's quite important, is it's quite complex in the health sector. Who can see what data about what people for what purposes? We have a lot of different types of healthcare providers, and we need to be sure that everyone only can see relevant data of its own patients. So that's why we have been developing a system in 5 steps: identification of the user, authentication of the identity of the user, verification of certain attributes, is he a medical doctor, is he a pharmacist, and so on. Verification of relationships. Does this medical doctor have a healthcare relationship with patients? With what patient? With the patient on whom they are asking for data. And what is authorized? What data can be accessed? We have taken into account, of course, the user expectations, because people don't want to have an administrative burden. So a citizen wants to have a one-time registration of his identity. Medical doctors want to have one-time a central database where they only have to prove once that they are a medical doctor. We need databases that indicate what healthcare actor has a therapeutic relationship with whom. It's sensitive data, because if you have a relationship with an oncologist, I know that you have a cancer, that it cannot be stored in a place where it is too easy. So there is indirect indication of the medical data of a person. So we organize this also in a decentralized way. The users want single sign-on. They want to have one time the proof of the authentication of the identity and the verification of characteristics, relationships, and so on, and not for every access again and then again and again. They want to be able to use as much as devices as possible and at a minimal cost, as well for the registration procedures, so to prove that that your identity is correct, that the characteristics, the attributes are correct. They also want not to pay a lot for the means of authentication and for the use of the system. So that's why we had an agreement on who is doing what. So in Belgium, if you want to prove your identity and get an authentication certificate, it's on your electronic identity card. It's the municipality that checks that you are the one that you pretend to be. You have to go physically to the municipality. For the companies, there are company counters, and they check whether the person that is coming for a company is entitled to represent this company. So every citizen has an electronic identity card that contains the authentication certificate. And there are a lot no, not a lot, there are 2 other means of with a bootstrap. Once with your electronic identity card, you can activate mobile authentication means that can be used by everyone, and that is free of charge to the users. For the characteristics, we don't put it on the card. It's too dangerous. The card, you cannot write on the card, so it is difficult to hack it. It exists for 25 years, since 2000. We don't have any problem, but the characteristics, the relationships are not on the card, it's in a database. And of course, a medical doctor has to prove, or a pharmacist has to prove that he has a qualification of a medical doctor or a pharmacist. And this is put in a central database at the Ministry of Public Health, where all types of healthcare providers are registered, and we use this database after the authentication of the identity to check whether it is an actor in the healthcare sector and what type of actor it is. There is some quality assurance measures within this database that people that have died and so on don't continue to be in the database, that there is no conflict and so on. When I started, there were a lot of databases on that level, and they were not consistent between each other. And then you have the therapeutic relationship. So every patient decides with what healthcare professional or with what healthcare institution he or she has a therapeutic relationship. There are a number of situations where we deduct this relationship from facts. When I go to a hospital, automatically there will be created a therapeutic relationship between this hospital and me for a period of 3 months. When I choose a medical doctor, he will ask me whether he can be my basic medical doctor. There will be a therapeutic relationship that is created for 1 year. So these are a number of situations where, based on a contact, there is a therapeutic relationship that is created. Above that, every citizen has access to a website where they can indicate what other people, a dentist or something like that, has a therapeutic relationship with. It's online. So when you close a therapeutic relationship, 2 seconds later, this person will not be able to access the data anymore. The therapeutic relationships are stored at the level of the sickness funds, because we don't want to know in a central way what type of medical doctors have a therapeutic relationship with what patients, because we can then deduct medical information. The sickness funds know it because they have to reimburse. So that's the normal, they know with whom you have been in contact. So that was the correct place to put the information, and the system is able to access the data at the level of the sickness funds. Of course, there are SLAs on all these databases, and we organize it by using the XACML methodology. So here you see, I will explain it. So at the right side, you have applications. It's databases, software that is available at the level of hospitals, at the level of healthcare professionals. They decide, every owner of an application decides what are the conditions, of course, according to what has been stated by the Information Security Committee, but decides what have to be checked before someone can access this application. The policy is defined in a policy repository. It's called the policy administration point, and it is the administrator of every application that indicates what has to be checked. So let's now take the case that my general practitioner, my medical doctor, wants to access the results of a blood analysis in a clinical lab and the result of a gastroscopy that has been taken in a hospital. So this medical doctor will put his or her electronic identity card in a reader or use the wallet or something like that to prove who he or she is and that she is the one that she pretends to be. So it is identification, authentication of the identity. He wants to have access to an application. We will have a look what types of checks have to be executed before giving access. You have a policy enforcement point that gives access or don't give access. You have a policy decision point that will tell to the policy enforcement point whether access is authorized or not. And the policy decision point will consult the policy administration, the policy of this application as known in the policy administration point. So let's take as an example that the application of the clinical lab, that the one who manages this application has said, okay, you have to check whether the one who wants to access the data is a medical doctor that has a therapeutic relationship with Frank Robben. So the policy decision point will then have access to what we call policy information points. It can be distributed. I told you that we have a database of who is an actor in the health sector and who has what type of capacity of the role. So the policy decision point will access the database at the level of the Ministry of Public Health and check whether it is an actor in the health sector and what kind. Second check has to be done on the therapeutic relationship. I told you that the therapeutic relationships are available at the level of the sickness funds. So the policy decision point will check in the database of the sickness funds whether there is a therapeutic relationship between me and that medical doctor. If so, the policy decision point will say to the policy enforcement point, you can give access, and the medical doctor will have access to the information. So if afterwards, because I told you that the doctor had to have access to the server of the clinical lab, but also to the server of the hospital, if the same conditions apply for other accesses, of course, it will be done automatically. This is a huge advantage on the level of security, but also a huge advantage about the ease of use for the medical doctor. Before the eHealth platform existed, what was the situation? Every application had its own credentials. When I went to my medical doctor, it's a woman, when I came to her after a blood analysis and a gastroscopy, she first had to look for the credentials to access the server of the clinical lab. Let's say a kind of password and a user ID and a password. Then she had to go to the server, she had to deconnect, and then she had another system, one-time password creation for the access to the database of the hospital. But she was using about 10 minutes of time to put it in, to access, to deconnect, to have the other access, and so on. Today, in the morning, she puts her electronic identity card. There is a session of 4 hours that is open. We have APIs, so her software can call APIs on the to get access to the service as well in the clinical lab as in the hospital. Her system knows that I'm coming at 10 o'clock. At 9:45, automatically, there will be connection to the APIs, and the 2 results are available on her screen when I enter. She has 1 minute to look to the data instead of 10 minutes to look for the data, and she has 40 minutes for me instead of 5 minutes. So everyone is using this, and we have the guarantee that it is done in a correct way. And as I told you, we have a kind of logging so that we know who has access to what data, in what cases, about what patients, for what purposes. And the patient can have a look at it. I have explained every concrete step in the system. And then I told you that we also want to use it in a cross-border situation. We want to be able, when a Belgian patient is in a hospital in Spain, that this medical doctor in Spain can also access to the relevant data of the patient that is available in Belgium. So it's quite easy, yes. We have a user in Spain. It's in Spain that they will have, that's also the agreement on the European level, that in Spain they have to check the identity and to authenticate the identity of the user, to check whether it is a medical doctor and to check whether there is a therapeutic relationship between that medical doctor and or another kind of healthcare provider, professional, between the healthcare professional and the patient. That has to be done in the country where the access is asked for. Then we get the information that this has been checked, and we will apply the authorization rule. So in fact, the PDP, the policy decision point, if there is an access that is asked for by a medical doctor in Spain, we have to check whether it is a medical doctor, but we don't have information about this person in Belgium. So we will ask a question to the PDP in Spain. Can you check and can you give the guarantee that these conditions are met? So this is a quite simple method to, in a federated architecture, to have exchange also cross-border. These are the authentication means that we have. So we have the electronic identity card, we have the wallet. Every member state of the European Union has to be an identity wallet by the end of this year. It's not that difficult because during the COVID period, every member state had an app that allowed people to download vaccination and test certificates after authentication. So it's a kind of wallet that existed, so it's not that difficult. Then we have rules. I told you it's very important in a complex sector with a lot of type of actors that everyone only has access to the data that is really needed for quality of care by the healthcare actor that asks for the information. So it's quite clear. The patient has to have given his consent. I told it in the beginning, but 98% of the people in Belgium have given their consent. We check, as I told you, the fact that the person that wants to access is a healthcare provider and that he has a therapeutic relationship with the healthcare user. There is a possibility in the Belgian system for every citizen to exclude healthcare providers to have access to their data. You are married to a medical doctor, you have divorced, you don't want your old partner to have access to your data anymore. So you can it's not used that much, but it is possible. And it's also integrated in the system. And then we have a kind of access matrix that indicates for every type of healthcare provider what type of data can be accessed. This is a decision of the Information Security Committee. So you see if the healthcare provider is excluded, no access. If there is no informed consent, no access. If it is not really a healthcare user that has a therapeutic relationship with a healthcare professional that has a therapeutic relationship with healthcare users, no access. And the data that are accessed, they are described in a access matrix, so it is not very readable, but here you have the types of healthcare providers, healthcare professionals, and there you have the types of data. It is checked. People will be able, so this is a standard matrix that we use today, but in the future people will have the possibility to add crosses to have access and to delete crosses, so that they can really say what can be used in what situation. There is a procedure, break the glass. If there is a vital need, if I come in a hospital, I'm unconscious, I cannot say anything and so on, there will be the possibility, but really a vital need, even if there is no consent and so on, to access the data that's agreed upon with the actors. And then we have the concept of circles of trust. As I told you, we don't want to know too much information on the health situation of a person. And it is not possible to, in a central system, to have a very accurate and actual description of the healthcare team in a healthcare institution. We have university hospital here in Leuven. I think there are about 8,000 or 9,000 people that are working there. It does not make sense that who is part of the healthcare team within the hospital of a certain patient, that this has to be declared in a central way. That doesn't make sense. So that's why we developed the concept of circles of trust. So if a number of criteria are met, if there is a kind of engagement that some measures are taken within a healthcare institution, they can define the healthcare team within this institution, and we will trust on it. Okay, so it's about an agreement about who is responsible of carrying out what type of authentications, verifications, and so on, how the results are exchanged, who is responsible for the logging, in such a way that there is a complete reconstruction that is possible when there is a problem, and retention periods on the logging. Yeah, yes? Yes. Yes, of course. No. They can download it. They can put it in their own healthcare, the patient electronic health record. That's needed, because if they want to see what is the evolution of certain measures, they have to do it. So, but that's clear. Once that the data is downloaded in the local system, they are responsible about what they are doing with it. There is in Belgium a law that states that every medical doctor or every health institution, even if there is no therapeutic relationship anymore between the doctor and the patient, has to hold the data for 30 years. That's a legal obligation. No, they have to do it in a secure way, but they have to be able to reproduce the data on the basis of which they have taken a decision for 30 years. That's a legal obligation. Okay. Yeah. Yes, I have to. So as you saw, we don't develop ourselves the software for the healthcare providers. A lot of the software is not really, it's not a fed client local. There are in a lot of situations, they are working in a kind of secure cloud. Yeah? We don't like too much a non-secured public cloud, so we can discuss about that. But they have the responsibility but the software providers are, as I told you in the beginning, we have a number of security criteria. We test the software packages on that criteria. So there are kind of meetings we have to show. It's not a hackathon, but it's they come together and they prove to do it. When I started with eHealth, we had about 35 or 40 software packages. Today we have 6. And we publish, so we have I can give you the criteria, they are public, and we publish what software packages meet these criteria, not only on the level of security, but also the level of interoperability. So we help yes, that's another thing I have to say. So a lot of healthcare actors get money from the RISIF, reimbursement institution, if they work in a digital way. They only get the reimbursement if they use a software package that has been checked by the eHealth platform. Okay, we cannot say you only can use this, because this would be against European law. But we can say we don't pay for it if you don't use a software package that is correct. So I think that in practice, these criteria are met. Okay. Okay, so the circle of trust, I explained to you, it's a kind of group of users of an organization for which the organization itself organizes a number of measures so that other institutions can have reasonable confidence that the information security measures are complied with. And here we have an overview of the type of criteria that we have in this circle of trust. Regulation, of course, principles of purpose, limitation, proportionality, user and access management, logging, information and education and awareness raising for the users with internal control systems and sanctions, compliance with the decisions of the Information Security Committee, and a number of criteria on enforcement. So you see that we have a system in place where the access to data is very well regulated and organized, and that the technical tools are available in a central way to meet these requirements. Then about encryption, so we have end-to-end encryption between all. So the eHealth platform is hosting, for instance, an eHealth box. But there is embedded encryption end-to-end in the eHealth box. As I told you, every healthcare provider creates its own key pair, puts the public key in a public database, and the private key is stored in a secure way in its system. Every 3 years, they have to regenerate the keys. At the beginning, it was the key pairs. At the beginning, it was quite difficult, but now they all know how to do it. So we have an encryption system when the recipient is known at the moment that you send information. And I don't have to explain it here, but creation of the key pair, use of the public key, of the destiny, and then the encryption that is possible by this person. But we have also situations where the destiny of the recipient is not known at the moment that we send information. If there is a medical doctor that wants to make a prescription for a drug, he doesn't know at what pharmacy the patient will go to get the drug. It's a free choice of the patient. So then we cannot encrypt, or the medical doctor cannot encrypt the data with the public key of the pharmacist, because he doesn't know what pharmacist it is. So in that situation, we are using symmetric keys, and there is a kind of division of tasks. So the encrypted message is stored at one organization. It's called recipe. So the encrypted prescription is put in a database outside the eHealth platform, and we have the decryption key. The patient goes to a pharmacist, puts his electronic identity card in a reader, gives access to this pharmacist to get a prescription. So based on this authorization of the patient, the pharmacist will be able to download the encrypted prescription and to get from the eHealth platform the encryption key in order to decrypt. So that's a system that we use. So you see, we can use these kind of things. These are basic services that can be used in a lot of situations. With a timestamping service, because a lot of documents have to be signed. That's the law that says it. When the medical doctor prescribes a drug, it has to be signed. Whether it is a drug that has to that the patient wants to get in a public pharmacy or within a hospital, it has to be signed. And it has to be a prescription, not a prescription. You have to be sure that it's prescribed. If there is a problem, it's about who is responsible for it. So what do? We take a document, we apply a hash algorithm to the document. This hash code, you know what is hashing, I suppose. The hash code is sent to the eHealth platform. We put a timestamp and we sign it and we send it back, and we get also, because the hash code doesn't contain any information, we put it in a database. Afterwards, we want to check whether the document that is signed has not been changed and so on and exists on that moment. Okay, we will re-ask for the main document. We will reapply the hash code, the hash algorithm. And if the hash code is the same that the one has been signed and timestamped, we are sure that there is nothing that has been changed to the system. This is used in every situation where you need an indication on the moment of the creation of the document and the one who is responsible for the document. So it's it's an alternative for a prescription and a signature. As I told you, we also act as a trusted third party for pseudonymization and anonymization of data. If you want to treat a patient, you need, of course, personal data on this person. But if you want to do scientific research, if you want to train AI systems, if you want to make policy advice, to evaluate policy, and so you don't need to know who it is. So that's why we created a set of tools to make it possible that data are pseudonymized or anonymized, and that researchers are people that have to do policy preparation can use this data. We have several types of tools, but one of them is quite interesting. That's what we call blinded pseudonymization. That's an online tool that permits to pseudonymize data without having the health platform to know what data is pseudonymized. So I will give you a concrete example. We have a kind of health vault in Flanders called Vitalink. Vitalink contains the summary, the patient summary on every patient that is living in Flanders, and for which the medical doctor has sent this patient summary to the health vault. Within the health vault, the data are pseudonymized. They don't know directly or indirectly about what individual patients the data are stored. So they can use the data to make statistics and so on without having to know what person it is. And only those who are authorized to access the patient summary as personal data will be able to de-pseudonymize it by using our service and to get access to the non-pseudonymized data. So this is a quite useful tool. We use it in a lot of situations where data need to be used for primary and secondary use. I think this is the last basic service that I have to explain, is reference directory. As I told you, we don't have a central storage of all health data about all Belgian citizens. It's decentralized, but then, of course, it is quite important that I live in Leuven, I go to the coast, I have a problem, I come in a hospital in Ostende. Okay, where are my data? So we created a system where every hospital in Belgium is connected to a network. We have 4 networks. Why 4 and not 1? I told you we're a complex country. So this has, as a model, been chosen. And Leuven is a Catholic university and Ghent isn't, and they want not to cooperate in one system. Sorry. So we have two systems in Flanders. And within this reference directory is indicated what about what people data are available at what level. We do it in 2 layers. We have hospitals that only treat 5 minutes. No? Okay, then I will 2 minutes. We have hospitals that are specialized in one problem. So if the hospital in Kortenberg, it's psychiatric patients. The hospital in Melsbroek, it's only MS patients, multiple sclerosis. So we don't want to know in our central system that someone has a file in Melsbroek, but then we know that he has multiple sclerosis. So that's why the connection, the reference to the hospital is in the hospital network on the responsibility of a medical doctor. And we have a kind of meta hub that refers to the network. So if a patient goes to a doctor anywhere, this doctor will be able, the software of the doctor will be able to check in the reference directory of the Crossroads bank, of the eHealth platform, in what network data are available, and then can get the information. Also, the health vaults are connected to this system. Yes, you can have a look. My presentation is public, but of course, you see 90 billion exchanges. Nearly all healthcare is based on this system in Belgium, so we have to guarantee business continuity. So we have a very transparent system and business continuity procedures in place. This you can read, so I will conclude. So I hope that you have seen that we have been able to have a good balance between, on the one hand, effectiveness, efficiency, exchange of data, and on the other level, guarantees on the level of information security, data protection, and that we do it on the basis of a continuous risk analysis, and that we have a set of types of measures in place, not only technical, but also organizational and structural, and that we are promoting it by design. Thank you for your attention.